Right, good I guess afternoon, everyone. I'm actually in Chicago right now, so it's still morning for me, but good afternoon. I think the majority of our folks that join us on Fridays are from the East Coast, so good afternoon to you all. Thank you all for joining us this Friday. As you know, on Fridays, we like to, I say, edutain at NMQF and talk about some issues in healthcare that are really important to us and the folks that work with us. And I think the first thing that's moderating today's one of the in the series of talks. Courtney Lang is probably one of the people that supports us the most. She's doing these has been leading a lot of talks on data. And if you know anything about NMQF, that's sort of our base, as we've always worked in the data, data equity, data health space. And today we're going to talk about intersectionality and disability, why inclusive data matters. And no one is better to do that than our very own, and I say very own because you may as well be employed with NMQF, our very own Courtney Lang, who is actually works in this healthcare space, is a leader in this space, and is actually a law professor by trade and training, a lawyer by training, a law professor is her day and summer job. And so she's joining us today, helping to educate us all. So I'm going to turn it over to Courtney, and she's going to lead today's webinar.
Thank you, Brandon, for the very generous introduction, and good afternoon and welcome to the audience. We appreciate your joining us for our continued series around data equity. And most importantly, today we are diving into the research. And so this, as Brandon alluded to, is truly foundational for the National Minority Quality Forum. So our gratitude is boundless to NMQF, to Dr. Gary Puckrin, to Gretchen Wortman, to you, Brandon, as well as to Blue Cross Blue Shield Association, Aishat Makbade, as well as David Merritt and the entire BCBSA team. And you're going to hear from some of their leaders momentarily. But before we begin, I want to acknowledge the work of the Data Equity Coalition, which is why we are here today. The Data Equity Coalition was established to advance more complete and consistent, meaningful data across race, ethnicity, language, sexual orientation, gender, identity, disability, and geography. So we come together in support of OMB's update to Statistical Policy Directive 15 that was refreshed after 30 years in 2024. But our work extends beyond the minimum. And so representative data are essential to understanding people's experiences, making sure that everyone is seen, represented, counted, noted. Identifying gaps in care and improving health outcomes is why we exist. So today's discussion and conversation actually builds on that commitment by exploring how intersectional identity shapes trust, comfort, and willingness to share race and ethnicity data, SOGI data, through the most important foundational lens of research, and bringing in the disability community, which is often forgotten, which we are champions for. So we are grateful again to our co-conveners of the Data Equity Coalition, NMQF and BCBSA. We encourage everyone to log into dataequitycoalition.com. And I want to now introduce our panel. Nancy Sheridan is a strategic marketing and brand insight leader at BCBSA. She is director of the Brand Insights team with more than 20 years of experience helping organizations turn customer market and competitive intelligence into business growth. She's been a tremendous partner, has attended the NMQF Summit, and she conducts research that supports strategy and messaging development around segmentation. Jennifer Patel, Jenny, is a powerful research leader consultant with BCBSA. She has been instrumental in the work that you are about to see. Dynamic strategy, brand customer insights leader focused on action and results, B2B and B2C initiatives across marketing, comms, strategy, brand, customer experience, and outcomes. And last, but certainly not least, one of our Data Equity Coalition members, Alan Morris, who is the Director of Policy for the National LGBTQ Task Force. And before joining the task force, Alan actually hailed from the immigration rights advocacy movement. He has secured a number of public policy wins and collaborated with the civil rights and social justice movements across the country. He's been featured in Business Insider, The Advocate, The Hill, Washington Blade, BBC News, among others. And we are most grateful for the partnership of our Data Equity Coalition members. So thank you, Alan, for being with us here today. So those were our housekeeping kind of overview, deep exhale. We are going to now turn the floor over to Nancy Sheridan and Jenny Patel, who are going to walk us through some tremendous research around race and ethnicity, SOGI, disability. And so with that, Nancy, the floor is yours for you and Jenny to kind of take us through how we got here today. I mean, it's a lot of research that you're going to be covering, but maybe just to begin at the beginning in terms of how we actually got to this point in time.
Yeah, happy to do so. And honestly, it's been a fantastic project to work on. And it's very heartwarming to just be able to do work like this for such a great cause. So thank you very much for having us here today. The reason why we really kind of, went all in on this topic of, data and collecting, race, ethnicity, sexual orientation, gender identity is because really it's the way for us to get to a point of improving health equity landscape. And the only way we can do it was having solid data. And we understood that there's gaps in terms of this data on personal identifying data in terms of your gender, your sexual orientation, because that all helps us get to the better outcome of stronger health outcomes and equity for all. So the leadership jumped on board, our partnership with Data Equity Coalition as well. And we jumped in and says, first, we need to learn before we run. Okay, so that's what brought this to light.
Fantastic. Well, we always like to make sure that when we're in community with data equity advocates, that we understand not just the work, but how we arrive to the work. And so that is an important context for the conversation. So maybe just frame the research question for the audience. And then, yes, please, let's dive into your work.
Great. Yes. So the big question is, we know what we don't know, right? So the team, before we wanted to, understand like, okay, let's just go out and ask these questions. We wanted to really spend time with people and the humans first. So we had to frame the question in terms of understanding really kind of people's lived experiences before we can say, oh, we can draft and create questions that we know folks will answer for us so we can get to our end state goal of stronger data that identifies these aspects and characteristics of people. So we want to understand people's views, their lived experiences, what shapes the reasons why or why they wouldn't provide personal information. So it's been a fairly long journey to get there, but we feel real proud of the work that we have. So let's jump in. So our time frame, we've went through several different research iterations to get here. And it started back really in 2021, where we just did a deep dive to understand what type of data that we had working with our plans and others to understand kind of where the gaps were with data. That was first, like, let's understand where we're at today. Then we scoped very specific research program and timeline to help uncover how can we get to our end state of how we should be collecting this information. We started out in 2022 after our initial discovery with some very depth interviews, one-on-ones with, people to just understand who they are, their lived experiences, how they think about their comfort level providing, say, gender identity, sexual orientation, race, ethnicity, and disabilities, because we need to understand where there might be some barriers or, concern about providing that information and why not, or what can we do to overcome some of those objections. So we learned a lot through these in-depth one-on-one interviews. Then we moved to the next phase of research, which was validating what we know. So we spent time speaking to folks. Now let's test it out. And we actually did a large scale quantitative survey. This is where we do actual surveys. You might be familiar with it, where you get a survey in your email that says, please, participate in the survey, and you're asked a lot of questions. That's a quantitative study. And we had, a very large population of folks completing the survey, over 10,000 interviews. So we were able to validate, the way that folks prefer to be asked these questions, because we learned in the first phase, people want to be seen. And so the way we structured the questions, we allowed them to say, this is the ideal way I would be like to ask my, gender identity question. This is my preference for sexual orientation. This is my preference for race and ethnicity. So we learned a lot from there. But we didn't stop there. We moved on one more step and layer deeper, which is this concept of intersectionality, which is so critical. It was the missing piece that we had, where we wanted to understand, the characteristics that make up someone are multifaceted. It's not just one element. So when I say intersectionality, I am talking about, people's individual characteristics that make up who they are. And it could be, 2 identities or 3, depending on the person. So for example, I'm Nancy, I'm a white female, right? And so that is my identity. Others have the identity of a African American gay person that has a disability. So they have 3 intersectional characteristics. So my lived experience versus someone else's lived experience in that example is very different, and how I might approach providing, my information is going to be very different because of, how I have been seen and my experiences in the world. So this research informs the role that intersectionality plays. We looked at all aspects of a person's intersectional characteristics and dove deep in terms of understanding the different aspects of that and some of the pressures that would influence their willingness to provide their gender identity, sexual orientation, race, ethnicity, disability status, etc. So we moved to understanding and learning through this work. And this was one of my favorite slides, because it really helps get to the point of identity is complex. And when people look at a decision of, I'm going to provide this information, yes or no, they're thinking of 3 different things: their identity, how they see themselves, or how I see myself. What do I identify as? How am I asked? And this one is very critical. So who is asking me for this information is the first filter. What are they asking? Where are they asking it? When and why? So for example, I'm at the doctor's office. You want to know these specific questions on gender and race, sexual orientation. Are you asking me in the office and when I'm there to check in for my appointment, being somewhat exposed? Or are you sending me an online survey ahead of time to fill out and complete? 2 different situations where I might feel comfortable addressing or not. So this is all what we had to consider. And this is what people go through when they're just saying whether or not they want to share the information. That is your lived experience, which is the halo over all of this. Have I ever faced discrimination comes into to folks' mind? Have I ever feared for my safety comes into mind? Have I ever had this type of information asked of before? Is there anything that I can recall? Am I safe providing this information? So it's multifaceted. So we really wanted our respondents to provide us, in their own words, who they are, which gave us a lot of context as to the willingness or the whys behind their comfort in providing this information. We asked respondents to describe who they are in detail. They provided video journals. We had conversation. It was a great, great conversation we had with folks. We learned that there are many layers. Identity really is evolving, and it will evolve for folks. And then some parts of identity are visible and some are not, which was a big learning, because the visibility aspects, are kind of the first way folks see us is what's on the surface. But, how we feel about ourselves could be very different than what's obviously in front of folks. And that's a nuance, and it's very hard to understand, but that plays into someone's comfort and their experiences in terms of providing information and the safety that they feel in terms of going to that, to be able to provide that information. Next slide. So for many, again, the most visible aspects of identity have really the greatest impact. The less visible layers are compounded beneath the surface. So your ethnicity or country of origin are often your first, aspects of your identity that are seen and viewed, and folks react to that most often first. One example from one of our respondents: I'm a Nigerian American with dark skin. There's no question what race I present as. Visible disabilities are also very, obvious in some cases. And, there could be folks who feel like, folks are staring at them, which causes, a little bit of upset. And, so those are some issues as well. Gender identity and sexual orientation are less obvious in some cases. But again, it just shows you the level of layers there is to identity, the easy visual aspects, but there's a lot going on underneath the surface. So we learned that people hold more intersectional identities. The weight of prejudice, stress, and trauma increases. Now, I learned something of Gretchen. We had a great conversation with her a couple months back where she's like, everybody has, intersectional identity. And it's true. Myself and Jenny, everybody, if you think about it, I'm a white woman that's older. So that's my identity, right? So everybody can claim an intersectional identity. And you bring what you know and your lived experience to every interaction that you have. And this is what this work did, and it uncovered a lot of that for us to get to the point of collecting really good data, because we are representing how to make folks be seen when we're asking these questions and overcoming some of these barriers. And it really comes to this idea of trust that Jenny will talk about shortly. So intersectional identities really combine. They create a really unique experience with several hurdles. Next slide. So folks often have experience with being stereotyped, understanding that sometimes there's no legal protections for folks. There's a lot of harassment, negative treatment, lack of positive representation, and then social political changes and challenges out there. There just are several hurdles that we know influence folks' decision-making process. And whatever we can do to, understand this better, the better opportunity we have to improve our data for those improved outcomes, which is super critical. People just want to be seen as a human, not by, the color of my skin or, the folks that I love. It's I'm a person with hobbies, things I enjoy in life, see me as me. And that's really what people are asking for. So it was really great research. So I would encourage everybody, if you have a question, to please put it in the chat. We will be addressing questions, at the end. So I do encourage folks to definitely ask questions. We'll be happy to address them. I'll take a pause here, for a moment. So is there anything that's come up? Have a chance to note it in the chat that you'd be most interested in understanding more, please do so. In the meantime, I will start turning it over to Jenny Patel, my colleague. Fantastic. She'll take us on the journey of trust and beyond.
Thanks, Nancy. So Nancy talked a lot about, first understanding the human being, right? Their identity, their lived experiences and such. The other side of that is also, before we dive into asking folks for sensitive information, there's a sense of trust that needs to exist, right? It's there when you have any sort of relationship that you start off with. And so one of the key things we learned from this research was trust is not something that's automatically given. It's conditionally given in certain cases. It's something we truly need to earn. And that's something that organizations, institutions, I think really need to understand and incorporate into their experience of actually collecting information, sensitive information. So some of the things that we learned is there are some institutions, organizations, relationships where the trust is easier to gain than in other situations. So having, talking to friends, family, partners, that, obviously there is trust that has been established. It's a longstanding relationship of sorts. There could be some similarities between the individuals in those types of settings. So that's where you can get more, the trust has been kind of established there. You can obviously visually see some cues in terms of like what Nancy had mentioned. This is an individual that is more similar to me, talks like me, acts like me, looks like me. So that, that's kind of a way to kind of establish some of that trust. The other way is also in some types of, verbal and nonverbal cues that can be incorporated. So I'll talk about the verbal first. That is where you actually kind of lay out why you are asking for information. What do you plan on doing with it? How do you plan on safeguarding? Because it is sensitive information that folks are maybe hesitant to give because they had an experience in the past where it didn't work for them, it worked against them. So just really being clear and transparent about the information that you're seeking, why you're seeking it, what do you plan on doing with it? And then how do you plan on safeguarding it so that it's limited use to the individuals that really need it and then stays out of sight for those that may not have a need for it? In terms of nonverbal cues, those are more of when you go into an organization, maybe a clinic or something like that, having signs, right, of allyship or, for instance, a recognized symbol like a pride flag, that automatically signals to an individual that this is a place that I can trust, right? They will fully see me, they will understand me. They are like-minded individuals. So information like that from a nonverbal perspective is also a different way of trying to earn that trust. Additionally, organizations that have demonstrated over time that they are looking out for individuals that may be underrepresented, marginalized, be outside of the normal traditional roles that male-female roles or otherwise. That is something that's also that's reflected upon or viewed more favorably in terms of willingness to share information. And then peer recommendations was another one. So folks like to talk to other individuals and say, like, basically they know like this is an organization that I can trust or not. Again, talking about openly about their experiences that they've had helps shapes another person's perspective. So what can we do? We talked a lot about trust here. And what can we do concretely that can help us earn trust? And we can turn to the next slide for that. So we have laid out 5 key things that we've learned from our conversations. And it really comes down to repeatable behaviors that we can demonstrate over time to earn that trust. It's not a one and done thing. It is taking several iterations, several conversations, several ways of demonstrating that we are a trusted organization or a trusted partner. The first thing is a transparency. Clearly, the 5 W's kind of we talked about already, right? Explaining why you need it, what do you plan on doing it, and more importantly, how is it going to benefit me? How is this going to help me? Making that personal tie-in so that the individual can see that this is really to better, deliver a better experience and make sure that you have better health at the end of the day. The second piece is the confidentiality. There is a lot of sensitive information. It can be misused. So reassuring, aspects of privacy. What are those measures that you're going to take? Having, links if you're collecting the information through an online mechanism, having links available saying here are the data protection laws that already exist, and then here are the additional measures we are taking on top of that to safeguard this information. So just know that it's going to be kept confidentially. Representation is another one. So having individuals, if it's an in-person kind of setting in particular, that represent a diverse set of backgrounds so that a person can see like, hey, the person I'm talking to, has similar characteristics as me. I can feel comfortable. I can feel safe sharing this information. And then the visible signs of inclusion that we talked about as well. The next piece is patient choice. Basically, not forcing someone to give information or making them feel forced. This is really a choice that then every individual has in terms of the information they want to provide and they do not want to provide. And when they want to disclose it and in what settings. So one of the things that we learned is a personal one-on-one interaction is a more comfortable setting to be able to provide this information. Just because you have that chance to have that conversation, establish that trust, get to know the person, understand where they're coming from, to have that better understanding to be able to ask these sorts of questions. And lastly, active listening. Before asking, listen first, right? Hear the other person's side of the story. Let them talk about what they've gone through so that you have a clear understanding before leaning into any assumptions you may have or predispositions that you may have based on it. So asking a lot of open-ended questions also is another way to get to know the individual before you actually jump in and have conversations. Which leads to the next one, who really is trusted and who kind of has to earn that or work a little bit harder to earn the right to ask sensitive information. So on the left-hand side, you see the trusted institutions are more of those like community health centers, clinics that we know have demonstrated over time what their purpose is. They've actually shown empathy towards individuals, understand the situation, have folks that may be working or talking to folks that are living through those same shared experiences, right? So those are the organizations that are more trusted. We'll be able to have a better chance of asking sensitive information and collecting that information. On the right-hand side are more of the distrusted organizations that probably have a little bit of a harder hurdle to climb over to be able to ask this. So emergency rooms, hospital settings, health insurers, government agencies are the ones that we have seen continuously pop to the top. And this is really because of one, that they've shared information in the past and it's kind of backfired on them, right? Or it hasn't been used as well. So those are the kind of things to keep in mind. Hospital settings, depending on what the situation is, the provider might not have a chance to establish a relationship with you. They might be in a situation where they need to obviously take care of you and provide the best health that they can before they can do that. So one of the things that we decided to talk about was where, when, and where is it safe to share my identity? And that moves us into the next slide, right? Longstanding relationships are obviously where you have the best opportunity to collect that information. But there are situations where it can be daunting, right? Especially in healthcare settings where you need to provide certain aspects to be able to get the care that you need. So private settings, making it clear why you need the information, what exact information you need, having options available that allow you to identify appropriately are all in pieces that would be needed. And you can see that in some of the quotes that we have here as well, that are essential. And then the other piece is not just the settings and how you convey this, but also clear communication strategies. What are those messaging opportunities? How can we make people feel more comfortable? And that leads us to this next slide here. The clarity. What are the benefits to me personally? For instance, I want to be able to direct you to the care navigation opportunities that exist, right? I want to be able to connect you to an individual that can help you with your diabetes management, for instance. I want to provide you with instances where you can go to like fitness centers and participate in programs to help you live your healthiest life. Things like that, clear cut, are important here. The other piece is demonstrating or showing how you will represent these individuals. So again, we talked about the cues, the visual cues, the verbal cues. having staffing that has diverse backgrounds so they feel more comfortable approaching an individual that is more similar to them. Making sure that we are protecting this information obviously is front and center. And then having that openness to communicate, ask questions, making sure it's not just a one-sided conversation, that there is a back and forth conversation that's happening there where there's Q&A to be able to kind of address any sort of questions that exist or concerns that may exist there. And taking these together, we have kind of three strategic themes that we've kind of talked about today that lead us to a core set of design principles that we'll be talking about real quickly. So one is identity is complex. Nancy hit on that several times here. We are not just siloed identities. There will be, we are multifaceted individuals that have shared lived experiences that actually factor into how we see ourselves and our willingness to identify who we are. Trust is earned through understanding the identity of the individual and being able to talk to folks individually and in a credible way. And then lastly, disclosure is conditional, right? It can be built, but it can also be broken down. So that repeated behaviors demonstrating that we are a trusted or credible organization is important. And so that leads us to what kind of practical guidance can I leave you with to establish this trust? The first one is personalizing the context, right? Understanding the individual, being able to communicate in a way that is relatable to them specifically. Also looking forward flexibly. So thinking about how that messaging or that context needs to change as we move forward in life. And obviously the demographic shifts that can happen, the generational shifts that can happen, and how cultural shifts can impact the way that we talk about and earn trust over time. Engage authentically, really be authentic. Is take that time to establish a rapport, that credibility that needs to exist before we head into asking sensitive information. And then be empathetic, respond to individuals in the way that they want to be responded to. Having clear channels. If they want to talk to you through in a one-on-one setting, be open to that and have the conversation because that is how they feel most comfortable. And then last one is meet people where they are. Giving choices, right? Having options to be able to communicate, signal empathy, right? Signal that you understand the individual and are inclusive. Those are all key things that are absolutely needed here. And these are things that you can obviously take away to be able to hopefully earn more trust. And obviously, at the end of the day, what we will achieve is better outcomes. A lot there.
Thank you, Jenny. Thanks so much.
Yeah.
That was great. Thank you, Nancy. A number of questions came in during your presentation, but I'm going to turn the floor over to Alan Morris first, and then we'll take a group Q&A and just get Alan's initial thoughts, reactions, reflections from the task force perspective. You talked about trusted organizations. He is representing one of the most trusted organizations and voices in the country as it relates to SOGI advocacy. So thank you, Alan, so much for being here with us today.
Thank you so much, Courtney, and much love to the Data Equity Coalition. Hello, all. My name is Alan Morris. My pronouns are he, they. I currently serve as the policy director at the National LGBTQ Task Force. I really want to start, Nancy, Jenny, I want to thank the Blue Cross Blue Shield Association for sharing this research, but more so for the courage to ensure the investment in SOGI data, right? When we look at examining race, ethnicity, sexual orientation, or any sort of gender identity data, it can come really sticky, right? People can get a little uncomfortable, right? But and it can come at a great cost politically. So I want to pour so much love and just thank you for that investment. Now, many of you may be like, who is the National LGBTQ Task Force? Well, guess what? We are the nation's oldest national LGBTQ-based organization with 53 plus years on the map, right? And we are activists who aim to drive the LGBTQ movement forward. We are organizers who sustain the hard-won progress. We show up at protests, celebrations, and you'll often see us in many different things on the Hill or even within state legislatures. I think one of the main things that we often say is we are let's make sure that I get this right, we are the progressive voice of the LGBTQ movement and the LGBTQ voice of the progressive movement, right? Some of our founding principles is making sure that people not only have a political home, but they can be seen and valued. And it's a space where they can come and there is no judgment, right? So when we talk about representation, it is about representing our people as best we can. Now, from a task force perspective, like there are a few things that stuck out to me and something that I hear often from many of our community members, right? The confidentiality and patient choice, as well as active listening, right? And I really want to lean into the patient choice and active listening piece. Um, for us, something that we often hear, even as we're working like on the Hill and we're trying to figure out what is it going to look like for them to expand Medicaid, Medicare, right? What is it going to look like for them to lean into universal health care versus always trying to nitpick and say what people can and cannot do with their body, right? And patient choice comes up all the time. It's like, I just want my doctor to give me a a plethora of options, or say, you know what, this is your best option. This is this is the least best option. And I want to help you make the best choice for you. Right. And really giving them that autonomy to make the decision. Right. We're often hearing from many different people like that they feel that their bodily autonomy is often like being like helicoptered over, like, can you do this? Can you not do this? Right. And so patient choice is something that comes up all the time. Active listening is something that I really enjoyed reading from you all, right? Because something that I have to tell my grandmother is I need you to listen to learn and not listen to respond, right? And so and that brings me to this, story. So my grandmother is a breast cancer survivor now for going on 5 or 6 years. And I can remember having a conversation with her about intersectionality while she was going through her treatments. And she was at her doctor's office and she was filling out her forms, and they were asking her all these questions about like her pronouns, what are her preferences, what are this, what are that. And so, she seemed a little bit like agitated about like, why are they asking me all these questions that's not relevant? And when we went to the back for, one of her sessions, it happened to be a person of the trans experience was also there getting the same treatment, right? And she realized in that moment that they were literally taking the same medications, the same hormones, everything was the same. And it really blew her mind that she was like, I need these hormones the same way this person needs these hormones. And it's not even for anything that is elective. It is something that is life saving, right? And so it really helped me pour into her and to get her to understand that sometimes we are, different, right? And I think it is important to just ensure that you look at the humanization of all people, right? And my grandmother, listen, I am a son of the South. She is a grandmother of the South, right? And so there are many factors in how she shows up from a religious aspect, right? And so in that moment, it was very, very pivotal for her to see that, you know what, we are all connected in like all these different ways, right? And there's also something that I, wrote down that I want to be very clear about. Audre Lorde said, I'm not free while any woman is unfree, even when her shackles are very different from my own. Right. And that's where we want to practice principled struggle. Right. And as practitioners and as, healthcare workers, this may be the first time you're hearing what principled struggle. Principled struggle is we may not agree on how we get there, but I want my patient to know that I'm not their enemy. I want my patient to know that I'm going to show up for them, and that whatever prior experience of discrimination, misgendering, inappropriate questions, breaching of, confidentiality, or any fear that they may have had prior to coming to me, I'm going to do my best to set any sort of personal feelings, religious feelings to the side and show up for this human being, right? And that's where we can practice principled struggle. I often have to lead partnerships with trusted communities. And I think some of the things that often comes up is leaders are trying to figure out how can institutions understand how questions can be perceived and what language resonates the most to give people that assurance, right? And seeing this data gives me so much hope, right? Because it's like this is where we can drop this off in many areas and say, look, they're doing the work, right? This is how you can lean into it, right? And it may not cover everything, but you know what? It's giving you a runway and a pathway to show up for your patients in many different ways. So we appreciate the longstanding partnership and collective support as a member of the Data Equity Coalition. And once again, I'm so proud of this data, and I really look forward to seeing how it's going to, impact the lives of not only patients but also practitioners. And again, thank you for having me.
Thank you, Alan, for those reflections and those comments. Deeply appreciated. I'm gonna bring everyone into community because I want Nancy, Jenny, and Alan to be able to respond to the questions that have come in, and I want to address something on the front end about disability because disability is in the title of this topic that we are covering here today. And I want to emphasize that the work of the Data Equity Coalition champions race, ethnicity, sexual orientation, gender identity, disability, and geography. And that the research has to be grounded from an intersectional lens. And I know, Alan, you and I talked a little bit about this ahead of this webinar, that a lot of times when we talk about SOGI communities, we never intersect with disability. We rarely intersect when it comes to race and ethnicity, but we end up grouping individuals by how we perceive them versus how they self-identify. And that's why I like the story that you shared about your grandmother and about patient choice and about personal choice, because you made a very important point. It is life-saving. It is life-saving. Nancy and Jenny, where is the foundational work in the research around disability amplified in your work?
Yep. Did you want to, Nancy,
Yeah,
take it
yeah,
first?
I'll speak to that. Yeah, we did interview folks that had a cross section of disability along with, the other aspects of an identity such as gender, sexual orientation. So it was cross-referenced. We did pick that up and we talked about it, but it really comes out similarly in terms of how people even with disabilities, there's a lot of similar tensions and prejudices that are occurring even among that. So it was really all encompassed within kind of the overarching story of building trust and empathy, because people are discriminated against, and there's prejudice and there's trauma, and it crosses everybody from disabilities who might be Black, African American, that's transgender as well. And it's just everybody's identity and what they see themselves as is a little bit different depending on how they view themselves personally. So it did come out, but not as obviously enough for this presentation, and we can always tee it up at a greater level next time. But it is actually part of it, right? So I'm not sure that came out as clearly or as explicitly, but it is there in the underpinning.
And I
Yes,
think,
thank you. Go
Yeah.
ahead, Jen.
oh,
Yeah,
sorry, just one thing I wanted to add to that was one of the key learnings was not all disabilities are visible too.
that's right.
So just keep that in mind, right? Like that's why I was talking about having that conversation, having that one-on-one open-ended conversation so you are able to see the person fully, right? See,
Exactly.
right. Mhm.
That's right. Exactly. And, you know, as a former board member for Mental Health America, that was one thing that we always try to amplify was the hidden disabilities, those that you cannot visually see. And that's a very important point to note. There was a slide that you all had that I think we need as a one pager. And Nancy, I think I said this before, but I'm going to say it on this call. And that's why do I need to fill out a form?
Mhm.
We get this question all the time. It happened at the NMQF summit. There is resistance, and Alan, you know this, there's resistance for people really being honest and organic and filling out the form because there is so much fear. There's so much fear. We want you to be seen, heard, counted, represented accurately. And the
Mhm.
system of care owes it to you to
Mhm.
acknowledge you in the way that amplifies your full self
Mhm.
and not hiding under, you know, these misnomers that make other people feel more comfortable because it may not be palatable to them. No,
Mhm.
this is about self-identity. And so I want to lean into that slide 5. Why do people need to fill out the forms accurately? Alan, can you give us, I know you told the story, but to just succinctly, why do they need to fill out a form?
I mean, I think more so, filling out the forms accurately not only will give the full picture to the practitioner, but it will
Yes.
also ensure that you're getting the best possible options for what your standard of care is, right? But I also just want to name that there are elements of safety, there are elements of fear that come into play when people are filling out a form. For example, I am a Black gay male with a hidden disability, and everybody cannot see that,
Mhm.
right? Everybody may not even hear that when they're talking to me.
Right.
But little do they know, I actually have a handicap placard, right? And
Mhm.
so, as someone that is showing up with these various identities, when I go into a doctor's office and I have to fill that out, the first thing that I think about is, are they going to see me as the problem? Is there going to be something that I'm going to hear that is going to deter me from going to this practitioner because they may not understand what that looks like? Or they may say, I don't understand what you're going through or how that impacts you, right? And so for me, it is about taking the courage, right? It's about also, once I feel that there is a element of safety and a welcoming space from the moment I meet that office manager or the first face that I see in that doctor's office, that's going to determine everything from that moment on out, right? So it is really about how we are representing the standard of care from the moment that that patient walks in, and how they're able to actually show up and how the questions are framed on the forms, right? Because sometimes the questions can be framed from a very what's the word that I want to use, a very less than smart approach, right? And some of the questions can definitely land as either ableist, right? It can often land as though there's not a standard of care on, like, hey, we want to approach this from a more human aspect versus just a simply gendered aspect, right? And so we're hearing a lot of those types of concerns on how there can be policies and procedures that are more welcoming, even in black and white and paperwork that people have to fill out.
Thank you so much. And Nancy, I didn't know if you wanted to speak to your slide 5 and if we can get that in a one pager type format. There have been a number of requests that came in with regards to that.
Yeah, we can absolutely do that. We can absolutely do that. Yeah. Okay, I can go back to slide 5 too, but yeah, I can do that for you.
Okay, and I wanted to, I'm gonna, because a lot of questions came in with regards to the intersectional approach to data collection, right? And so you've all addressed it kind of holistically, but I do think it's worth taking a pause because sometimes individuals that are collecting, particularly health data, make assumptions about patients when they come in the door and don't ask them the appropriate questions. And I think you all kind of alluded to this a little bit. So they may think that your phenotype is such that you may not be speaking a different language. And so then that becomes a barrier, completely discounting the entire Afro-Latino, Pan-American movement, if you will, and representation. And it happens all across the board. We make assumptions by what we see, not based on what we know. How do you recommend that we overcome that hurdle? Because this speaks to both disability as well as race, ethnicity, language, geography, all of the things. How do we overcome the barrier?
I'll kick things
Research
off.
perspective. Yeah, go ahead, Jen.
Yeah. And I think it's more about the experience, right? You kind of just hit on that. When you, from the minute walk in, what is that experience like? And making sure that um, it's a safe environment. Um, sorry. And moving away from, just being able to collect the information, but more of like that experience, like it's a welcoming experience. We are here to help you. Let's have a conversation, get to know each other better.
Yeah, it's a lot of training and like rethinking our approach to engagement and how we think about people. So we said this through a lot of the design principles that Jenny had shared, and we were ideating with plans. It's like, we have to spend a lot more time training and educating people, and that's really the frontline work that has to happen first, right? And it's going to take time, right? And then standardizing some of the questions to some degree that to ask it, and then just education, education, education. That's where we're going to win.
Yeah, the data standards part is one of the areas
Yeah.
that Data Equity Coalition leaned into from day one. And there's the issue brief on our website that actually speaks to that. And, lots of gratitude to Gretchen Wortman for leading the work on standardization. I want to acknowledge, Michael, in the chat, you talked about providers also being open and revealing their intersectional identity. Completely agree around patient and provider concordance, just like we had championed racial concordance. Patient and provider concordance leads to better health outcomes, 100%. Alan, do you feel like that is an important step to include in advocacy, just helping to socialize with providers why they're being honest about how they present helps to take away some of the fear, the trust issues, the anxiety about an engagement in a health encounter?
Definitely, definitely. And thank you so much for naming this. Honestly speaking, if I walk into a doctor's office and I start to have a conversation about where my anxiety and stressors and like all these things are landing, and I have a doctor that can not only empathize but also share their input on that, I'm immediately locked in with them. I'm like, okay, they get it, and I can share this input with them, right? Versus it being a place where someone is just listening and then they're responding, but they're responding from a very, like doctors and practitioners are trying to respond a certain way. And it can mean for many different things, right? It can be for liability purposes. It could be for, standard of care on how that practice may want to do things. But doctors and practitioners, y'all are human too. And you deserve to show up and be your full self in that as well. You may have a hidden disability that people may not see, right? So the same way you want your patient to come up and be their full self, we need you to do that same thing. So I would totally say, yes, bring your full selves forward. And I can understand how that can be a different level of, impact and accountability when you factor in the different intersectional identities, right? And
Yes.
so I do want to name that.
Thank you. Nancy, go ahead briefly. We got like
I
1
love
minute.
that comment. No, I love that comment. And I'm just bringing up something that I think is, we don't think about it often. And I know this might be a small little example and hopefully, but like females like to identify, some females feel more comfortable with a female gynecologist or doctor. And that's the exact example right there of you want to be seen, heard by someone that can understand you. And so that would be like a way to kind of understand that model a little bit more. So how can we do that to be more comprehensive for everybody to be seen similarly, right? That's an obvious one because it's a visual situation, but there is that need, and we obviously know that. So we've got to be able to be doing better and something similar to that model somehow. I don't know, but it just that's what came into my mind. It's like you
Yeah.
understand, you have my lived reality in some way. So
And so, exactly. No, I think that's an important distinction. I wanted to also make sure that we address this one last question that was actually the first one that was placed into the chat about what happens when there's tension between identities within an individual who's presenting, and does the research require an individual to prioritize or rank their identities? I think that's a beautiful question. Do we rank our identities? I mean, how does that work from a research data aggregation or disaggregation perspective?
Yeah, I think you're on mute, Nancy.
that's a complex question, and I don't know if I have an answer right now. Yeah, so our research, when we did our research and execute our research, we didn't require them to prioritize or rank their identity. We just asked them, and then we basically categorized folks based on being a Black, African American, transgender, but we didn't have them prioritize how they view themselves in the research. That came out just organically through the "Who are you?" description and discussion, and journaling. So that just came out naturally. We would not force that. Aspect. I mean, I'm not sure from a research perspective what we were doing that would make sense, but uh, maybe for other use cases it might make sense to do that, but not from our research lens perspective. That yeah,
And
I don't know, Jenny.
oh, okay, Alan. Okay, go
Yeah.
ahead.
Jenny, were you going to say something, Jenny?
No, I would just gonna quickly just say, I think if a person was to prioritize, one of the things is, I think we talked about it, the identities that can be easily seen, right, probably are prioritized by individuals first, because that is how we view it through our eyes first, right? So that's probably, if anything, that's how it's happening. But go ahead, Alan.
Robin, thank you so much for this question. And I just want to bring us back to one of my first points, principal struggle. How
Mhm.
can I show up, even though I may not understand, even though the identities may be overlapping or there may be some tension there, acknowledging that there may be some tension or you may not understand, but you want to show up for that individual, even in the midst of principal struggle, it's going to bring you further along. Robin, I promise you, if you just drop in, I want to be here for you and I want you comfortable, even though we may not agree on everything, I want us to model that principal struggle. I promise you things will shift.
Quickly, panelists, 30-second final thought. 30-second final thought. Alan.
Live in it, stay in it, but also give yourself grace and
There,
model principal struggle as best you can.
there it is. Jenny.
The key is to build trust and that relationship before anything else can go on, move forward.
Thank you. Nancy.
Listen without judgment. Listen without judgment. Yeah.
Exactly.
Create safe
Well,
spaces.
safe spaces. And that's what this webinar is entitled to do. Intersectional identity. We are entitled to create safe spaces for the community at large. And we are so grateful for the National Minority Equality Forum providing this platform, to Blue Cross Blue Shield Association for the research and for co-convening the Data Equity Coalition, and to all of the Data Equity Coalition members. We are actively listening, and we did hear the feedback around the disability justice, and disability advocacy. I want to acknowledge apparent and non-apparent, apparent and non-apparent. So thank you for clarifying that versus hidden and invisible. There was no stigma attached to that. We've had many terminologies that have been brought forth, and we want to make sure that we are fully open with open hearts and minds to acknowledge everyone. We will follow up with a very specific session on disability research so that we can account for some of the considerations with regards to any confusion on the research side. But we do hope that principally intersectional identity was amplified and that we all come to the table with lived experiences, most of which are all intersectional, as Gretchen had informed us so beautifully before. And so with that, we want to acknowledge not just the work, but all of the work that's done in community, and that data remains the foundation to the health equity movement. Today and always, we want you to be seen. We want you to be counted. We want you to be represented. With deep gratitude, dataequitycoalition.com, dataequitycoalition.com. Gracias por estar aquí hoy. Thank you so much.